Hi, this is Terry Kuti with Deep Sea Foundation. I am in San Antonio talking to Dr. Minas Chrysopoulo with PRMA. Welcome, Dr. C.
Hi.
Glad to come visit your office.
Yeah, it's nice to have you back.
Well, thank you. It's
Yeah.
nice to be back. It feels
Yeah.
like home.
Yeah. Not surprised, yeah.
So while I was sitting waiting while you were with your patients,
Mm-hmm.
I picked up a
Yeah.
brochure.
Yeah.
This is something,
Cool stuff.
yeah, and actually, a year ago when we did some videos, you told me, you said, watch this space.
Mm-hmm.
It's happened.
Yeah, formal
Can you tell us about it?
Yeah, so we were doing lymphedema surgery. We've been doing it for quite some time now, but not all the procedures. So we were offering lymph node replacement. It's called a vascularized lymph node transfer, where you take lymph nodes from one part of the body and move them to the armpit area to replace the lymph nodes that were either removed or damaged by the lymph node surgery for the breast cancer surgery.
Is excuse me for the interruption. Is this in the presence then of lymphedema when a patient comes in?
Exactly.
Okay.
Yeah. So a lymphedema patient, we're still seeing lymphedema because of breast cancer surgery, especially in ladies who have had radiation. There are several risk factors, but removal of lymph nodes is associated with a risk of lymphedema, depending on how many lymph nodes are removed. Even sentinel lymph node biopsy can give you lymphedema, but it's very, very low risk. If you remove a lot of lymph nodes, the risk goes up, and then if you add radiation to that as well, then it can be a very significant risk. So lymphedema patients now have surgical options. So they do have to be tuned up with lymphedema therapy before they have lymphedema surgery.
Prior to seeing you.
Yeah, we used to tell people, microsurgeons, lymphedema surgeons, we used to tell patients that you're only a candidate for lymphedema surgery once you've failed conservative therapy. But now it's becoming clear that that's probably a mistake. And we certainly feel it's a mistake, because if you wait until the conservative therapy, in other words, the physical therapy, fails, by that point, all the scarring has really kicked in. The lymphatic channels have fibrosed. They've become basically...
You got more work to do.
Well, it just doesn't work.
Yeah.
So you've got to jump in there where you've still got part of the lymphatic system functioning, so you can decrease the amount of lymphedema. There's nothing that's curative yet for lymphedema, but we're seeing some very good results. And this pamphlet we made here because we've now formally started a lymphedema program, and we're offering what's called an LVA, which is a bypass.
I was looking at it. They're both.
And that's something that we haven't always offered, and that's the new component.
Okay.
So the LVA is basically, it's a lymphatico-venous anastomosis. What that means is you take a lymphatic vessel, a lymphatic channel in the arm,
okay,
and you bypass a blockage in the lymphatic channel by connecting that lymphatic channel to a nearby small vein. So it's a bit like jumping off the highway onto the access road to bypass a wreck, and then getting back on the highway once you pass the wreck. So that's what we're doing with these LVAs. And so that's a very low risk procedure. It's pretty straightforward. It's technically very challenging, but it's an outpatient surgery procedure.
You just answered my next question.
Outpatient.
Local?
Can be. So some places in the country actually doing these under local anesthesia in a kind of a office setting.
Yeah.
Most of us are doing them still in the hospital setting, in the operating room, as outpatients. That's what we're doing.
What's the recovery like? I mean, when
pretty straightforward. It's low maintenance. You have to jump back into lymphedema therapy again. So you get tuned up before, have the surgery, and then continue with lymphedema therapy once you've healed.
Sized for sleeve?
All that stuff, yeah.
Measurement.
All that stuff's done before.
Yeah.
So you've got to be connected with a certified lymphedema therapist. That's absolutely crucial. No one should be having lymphedema surgery unless they've been evaluated by a certified lymphedema therapist.
Yes.
And they've had the therapy and they've gotten tuned up.
Yeah, I think it's important too when women have lymphedema. This has been brought up to myself and a couple of other advocates too, though, that they'll just say, "Oh, can I go get a lymphedema sleeve?" And both of us have told them, it's Kirsten Litz, who I think you know. She has very mild lymphedema, and she always tells them, "You've got to get measured for these. You know, to have an accurate fit for a sleeve, you've got to be measured."
Yeah, it's not the kind of thing you want to do off the shelf, typically.
Right. So.
Yeah, so we're very excited about it. Dr. Garza is actually the one who's heading up the program. So he's done a bunch of these. So we're very excited about it. So yeah, it's and a lot of patients, obviously, who have had mastectomy, radiation, who have never had reconstruction, we're excited because we can now offer everything. In conjunction with the reconstruction. So it's.
Well, I've been watching the space and all of your social media feeds, and I'm excited about it. I'm excited to tell the patients about it. It's really good stuff.
Definitely have to get the word out for sure, because lymphedema is still a problem. It doesn't look like it's going away. We're moving more and more towards doing less surgery, which is a good thing. Yeah. But it's still a major issue for sure. Yeah, and problematic too, if I might throw this in the mix, and you're very transparent about it in your brochure. And I just left the breast surgeons conference, and the amazing Kathy Bates spoke there. Yeah, she's awesome. Yes, she is. And one thing we're all collectively working on is the cost of this. I know there's some legislation out there now even that's working on getting more of the lymphedema treatment and costs covered by insurance. So thank you for being so transparent about it in your brochure. Oh, no, thanks for mentioning that. That's important because unfortunately it is on a case-by-case basis. It depends on the situation, depends on the patient, depends on the insurance plan, depends on what else you're having done. So unfortunately, we can't say it's always covered. Yeah. What we can say is that we always try and get it covered. Yep. But it's definitely case-by-case basis, unfortunately, because it's still deemed by many insurance plans to be experimental, which is kind of either investigational or experimental. It's a very, very common thing to come across with insurance companies deeming procedures experimental or investigational, because then they're not covered. Well, if Miss Bates has her way, that's going to change soon. She's a fierce advocate, and I want to thank you for being so transparent about it from a patient perspective. Good stuff going on. Thank you. Thanks. Good to see you again.